Hey everybody, welcome to Hormone Lecture. This chapter has a lot of information, so please reach out to me if anything is not clear for you. I want to make sure that you guys understand the hormones and why this is important for surgical technology. So, endocrine system review. Remember that hormones are the chemical messengers that travel through our bloodstream and help tell the rest of our body what's going on and what they need to do to maintain homeostasis. So some of the things that hormones do, there's 4 different things. First is they're going to regulate the internal chemical balances and volume of things such as our blood volume. So any of those kind of regulatory things are going to be done by hormones. Any kind of response to environmental changes. So when we are under stress, when the temperature gets hot or cold, if we have traumas, hormones are going to regulate our response to those kind of situations. Hormones are also responsible for stimulating our growth and development, starting from the time that we are infants and actually in utero up until the day we die. We still have things that are growing and developing in our brains and throughout our body. And then lastly, hormones are in charge of reproduction. So you have different hormones. Actually, you have the same hormones, but you have different concentrations of those hormones depending on if you're male or female in your reproductive system. So let's start with the pituitary gland. Let's start at the head and work our way down. So the pituitary gland is also known as the master gland, and it controls a lot of the body's stimuli. So we're going to think of the pituitary gland as being like the pilot of a ship that has to know everything that's going on around the ship to be able to keep the ship safe and to guide it safely to harbor. So in the pituitary gland, though, there are 3 different areas we kind of need to know. The adenohypophysis is the front of the pituitary gland, or the anterior portion of the pituitary gland. And the neurohypophysis is the posterior portion, or the behind portion of the pituitary gland. And then there's the hypothalamus, and the hypothalamus isn't really part of the pituitary gland, but it sits right above the pituitary gland, and it actually secretes things that help the pituitary gland know what's going on. The pituitary gland works back and forth with the hypothalamus to regulate a lot of the body's systems. Now, the adenohypophysis is where most of our regulatory hormones get sent from. So we have GH, TSH, LH, FSH, and ACTH, as well as prolactin. I want you guys to honestly know what each of these mean. So I'm not going to tell you. I want you to go in your book and find what each of these mean and what they do and what they work on. So use that as a homework assignment. Even though it's not an official homework assignment, I want you guys to really get this alphabet soup down. And I have a feeling if I just tell you, you're not going to dig deep into the book. Now, the neurohypophysis, the back portion or posterior portion of the pituitary gland, only secretes 2 hormones, and they're oxytocin and vasopressin. And the one that we are most concerned with as surgical technologists is oxytocin. And this is due to the fact that when we are performing C-sections during surgery, we need to make sure that we have oxytocin in the room to be able to give the mom, to be able to help stimulate uterine contractions if the uterus doesn't continue to contract after the baby is born. And the reason that's important is that we want to control uterine bleeding at this point. So even though your book says that we need to push the placenta out, we can go in and dig the placenta out if we need to. But what we really need is those contractions to help constrict those blood vessels, give them time to clot, so that the mom doesn't bleed out after the baby is born. So yes, we do want to squeeze the placenta out 100%. We want the placenta to come out. But we really want to control the bleeding, because bleeding can be a big problem for moms after giving birth, whether it's C-section or vaginally. We just only see the C-sections from a surgical point of view. So the hypothalamus actually makes oxytocin and vasopressin, and it runs down from the hypothalamus into the neurohypophysis, and then is secreted from the neurohypophysis. But the hypothalamus is where those hormones are created. And the hypothalamus sits directly above the pituitary gland. And then not only does it make oxytocin and vasopressin, but it also makes some other hormones and secretes them. And these are GHRH, TRH, GnRH, GRH, dopamine, and somatostatin. Once again, I want you to dig into these. I want you to figure out what they are, what each of these abbreviations mean, so that you can understand what the hormones are that are being secreted out of this gland. This is quite a list. So make sure you understand what these are, where they work in the body, and kind of highlight what you think might be important for us to know in surgery. This is just a representation of the pituitary gland and what it looks like and where it sits in our brain. So the pituitary gland sits right here. The sphenoid bone sits right here. And remember, the sphenoid is the back of the nose. So we can actually go through the nasal cavities and get to the pituitary gland by just cracking the little sphenoid bone back here. And then we can do a transsphenoidal hypophysectomy. So going through the sphenoid bone to get to the pituitary gland, also known as the hypophysis. So we have our anterior lobe and our posterior lobe. And then this is our hypothalamus. It sits right up top here. And there is a duct, actually a nerve and a duct that run from here to secrete those vasopressin and oxytocin hormones. All right, let's talk about the thyroid gland next. The thyroid gland is most actively involved in metabolism. And so as long as our thyroid gland is working well, we have a normal metabolism. However, if the thyroid gland stops secreting as much, or the pituitary gland actually stops secreting as much TSH, it can interfere with the T3 and T4 that the thyroid gland produces, and we have hypothyroidism, meaning that we're not getting as much of the thyroid hormones as we need, and the metabolism slows down. This also causes other systems in the body to slow down as well. Metabolism is kind of the one that we see the most often in these patients, but it also causes bradycardia. Patients get tired and sleepy. They don't have as much endurance, and they're just less mentally alert. Sorry, excuse me. But then we also have a condition of hyperthyroidism, which is also called Graves' disease. And this is actually where we speed everything up. So the metabolism speeds up, so these people have a very hard time gaining weight, maintaining a normal weight. They're also very restless, nervous. They do a lot of sweating because their muscles are contracting so much that they're producing a lot of heat. And they have tachycardia, not surprising when your muscles are contracting a lot. So what are the 3 thyroid hormones that we really need to know about? T4 and T3, and these are regulated by TSH. So TSH comes from the pituitary gland and interacts with the adenohypophysis of the pituitary, and TSH comes from the adenohypophysis of the pituitary, comes down to the thyroid gland, and asks the thyroid gland to begin the production of T4 and T3. T4 and T3 then regulate the metabolism. They also regulate some growth and development. If you have abnormal thyroid in children, it will actually stunt their growth and cause mental development delays. And T4 and T3 require iodine to be made. So that's why when you buy salt at the grocery store, it's always iodized salt, because we were finding that Americans weren't getting enough iodine in their diet, so they decided to put it in salt, because we always put salt in almost everything that we make in the kitchen. So that's why we have iodized salt. Calcitonin. Calcitonin is the other thyroid hormone, very important in our calcium and phosphate ions in the blood. So calcitonin is what's going to cause osteoporosis when we get older, because it is trying to regulate calcium. We may not be getting enough calcium. And so to have enough calcium in the blood to maintain normal heart functions and other physiological things, it will break down calcium from the bones and create the uptake of calcium into the bloodstream. Calcitonin can also act on the kidneys to get rid of these ions. So calcitonin can go to the kidneys and say, hey, I know we broke down some calcium from the bones, but now we don't need it. So let's just go ahead and excrete it into our urine. So calcitonin, very important for our, calcium regulation and in turn our muscle contractions. All right, parathyroid. Parathyroid glands. There are 4 parathyroid glands, and we talked about this earlier when we did thyroid surgery, that there's 1 in each of the upper poles and 1 in each of the lower poles. Parathyroid glands monitor our calcium ion concentrations in the blood, and they produce parathyroid hormone, or PTH, and PTH will stimulate the osteoclasts, which release more calcium from the bones, and it will inhibit the osteoblast, which means we're not building any more bone. So we're going to keep that calcium in the bloodstream as opposed to putting it into the bones. It also enhances the reabsorption of calcium in the kidneys. So if we don't have enough calcium in the blood to begin with, we're not going to allow the kidneys to excrete it. So we have PTH telling the kidneys to keep all the calcium it can. This also helps stimulate the formation and secretion of calcitrol in the kidneys, which is another protein, and this will increase the absorption of calcium and phosphate by the digestive tract. So the kidneys also secrete a tiny bit of hormone, but this actually works on the intestines. So the intestines are going to start absorbing that calcium a little more efficiently than they would without the calcitrol. So review questions. What is the anterior part of the pituitary gland called? What is the most important hormone for the ST to know? What is the most important hormone for the ST to know that is produced by the neurohypophysis, and why? And what does TSH control? And what is the effect of PTH on osteoclasts? All right, let's talk about the adrenal gland now. The adrenal glands produce, store, and secrete epinephrine, norepinephrine, and dopamine, and these collectively are called catecholamines. What do catecholamines do? They prepare the body for the fight or flight response. So remember I talked about stress, trauma, those kinds of things. Those are all fight or flight responses. So when we are under a large amount of stress continually, it is not good for our body because we're constantly in that fight or flight response. So that's why it's so important that we try to regulate the stress in our lives. I know I'm kind of preaching to the choir because you all are students and you're surg tech students, so there is a lot of stress in your life. But hopefully in the next few months, there won't be as much stress in your life and you'll be able to relax and just enjoy your jobs. So what happens when we prepare the body for the flight or fight response? Well, we're going to increase the heart rate. We want to get more oxygen to the muscles. So we're going to increase the heart rate. We are going to increase the cardiac output, which means we're going to increase the amount of blood that the heart pumps with each pump. So once again, getting more oxygen and nutrients to the muscles. It's going to cause vasoconstriction. Vasoconstriction in our trunk especially, because we want to have more oxygen and nutrients going to our extremities so that we can either fight or run. It's going to increase our blood pressure. This, once again, increasing the perfusion of those muscles. Increased respiratory rate. We can't have increased oxygen if we don't increase the amount of times that we're breathing. And it's going to decrease our digestive activity because when we're in fight or flight mode, we're actually telling our body that we may have to run and that we can digest our food a little bit slower so that we have more energy, more oxygen going to the muscles. All right, so let's talk about epinephrine in particular. As you guys know, this slide is completely a review for the most part. When injected, we only inject epinephrine in extremely dilute concentrations, 1 to 100,000. I don't know why this extra 1 is here. That's a typo on Tracy's part. Or 1 to 200,000, and it causes local vasoconstriction. So it only vasoconstricts in that tiny little area that we injected it in. When we have it in higher concentrations, though, like 1 to 1,000, it causes systemic vasoconstriction, resulting in life-threatening elevated blood pressure and tachycardia. So we never put 1 to 1,000 epi in a syringe. It's only ever placed in a topical manner. And every vial of medication with epinephrine will have a red text stating the concentration of epinephrine, just as a visual reminder that the medication does contain epinephrine in it. So all of your labels for your local will have the medication in red, and then down here in red it will also say not for epidural or caudal use, generally if there's epinephrine in it. But this red label is reminding us that this does have epinephrine and to be cautious with what we're doing with this medication. All right, steroids. Steroids are produced in the cortex of the adrenal gland. There are several different types of steroids. The most common used in the operating room is glucocorticoids, and we use those to reduce inflammation. So we may actually inject them or dribble them actually into a surgical site so that the inflammation will decrease, and hopefully the healing of that area will be less painful for the patient. We can also use steroids medically, so not surgically, but medically, to reduce organ rejection. So we will decrease the inflammation around the organ tissue, and hopefully the immune system will not destroy it as quickly or at all. All right, let's talk about the pancreas. First rule of general surgery is don't poke the pancreas. However, we're going to poke the pancreas a little bit because we're going to learn about it. So, pancreas is divided into 3 areas. It's got a head, a body, and a tail. Pancreas is one of the few organs that has 2 different functions. It functions as an exocrine organ, and it also functions as an endocrine organ. What does exocrine mean? Exocrine means that it's going to help with digestion. So the pancreas secretes digestive enzymes. Remember, they're taken down the pancreatic duct and into the common bile duct and then into the duodenum. So all those digestive enzymes are produced in the pancreas, flow down to the duodenum. Then we have the endocrine side of the pancreas. Endocrine side, there are 2 different types of cells that we are concerned with. The alpha cells are the ones that produce glucagon. And what glucagon does is it tells the liver that our blood sugars are getting low. And so then it starts breaking down glycogen that's been stored inside the liver, and this increases our blood sugar levels. Then there are beta cells, and the beta cells in the pancreas produce insulin. And what insulin does is it's a molecule that kind of grabs onto the glucose and allows the glucose to pass through the cell membranes into the cells to be processed for energy. So insulin is actually going to decrease our blood sugar levels. So it's important to know what each of these 2 do. Your book also talks about diabetes, that the beta cells are attacked in type 1 diabetes, and the immune response, it's an autoimmune disease. The immune cells go in and completely destroy the beta cells in the pancreas. So diabetics that are type 1 don't have any functioning beta cells left in their pancreas. However, they do have functioning alpha cells, so they still can increase their blood sugar levels with glucagon. It's just a little more delayed. Type 2 diabetes is where the beta cells either can't produce enough insulin because the person's overweight, or the insulin that they produce is not effective in decreasing the person's blood sugar, or the cells, cell membranes, the receptors for insulin, are not produced correctly, and so the insulin isn't allowed to bring the glucose into the cells. So type 2 diabetes has lots of different facets to it, and it's one of the pandemics that we're having across our world, but it's endemic in the United States. The United States has a very large population of type 2 diabetics, and so there's lots of research going on how we can help people understand diabetes, but also what can we do to help them live better lives with their diabetes. So review questions. Why do we add epinephrine to local anesthetics? What concentration of epi is safe for injection? Why are steroids important to surgery? And what functions do the pancreas control? All right, let's move on to ovaries. Ovaries produce progesterone and estrogen. These hormones are critical to the development and maintenance of female sex characteristics. This is not necessarily the only thing, the only hormones that females have for their sex characteristics. Females also carry some testosterone. It's just at a much lower level than it usually is in males. So the estrogen and progesterone are the ones that are produced in more mass quantities, causing the development of female sex characteristics. These hormones are used medically to treat several diseases and to prevent pregnancy. However, they're not used surgically. We don't inject progesterone and estrogen into our patients in the surgical suite. So these are all done outside of surgery. Estrogen is huge in hormone replacement therapy. So women that are either going through menopause or have been through menopause, or surgically, if we have to remove their ovaries, we're going to put them into immediate menopause because they're not going to be able to secrete their estrogen or progesterone anymore. And so we need to make sure that they have enough estrogen and progesterone to be able to have normal secondary female sex characteristic functions until they are done going through menopause. All right, the testes. The testes produce androgens, and androgens are responsible for the development and maintenance of male sex characteristics. The most commonly known androgen is testosterone. These hormones, once again, can be given off of, won't be given off of our back table. They will be given medically to treat different diseases. Sometimes erectile dysfunction. A lot of times, men, as they get older, start to produce less testosterone, so they can take testosterone to kind of boost their energy, sometimes their libido. Obviously, gender affirmation, we use both estrogen and testosterone to help people develop characteristics more in line with their gender that they are feeling. So, yeah, that's what kind of our sex characteristic hormones in a nutshell. So I think that covers everything that we need for hormones this week. If you have any questions, please let me know. I hope you all have a great week. Bye.